Hi, my name is Ankur Gupta. I'm a general dentist. I've been practicing dentistry for a little over 21 years. And I do mostly bread and butter stuff. Even though I dabble in some dental implants and some endo and some bone grafting, the majority of my practice is still diagnosing decay and trying to treat it. And one thing that really bothers me about that process is how imperfect it is. First of all, when a person has decay, our first instinct, which we were taught in dental school, is to drill out all of that decay and fill it back in. And that's pretty cool. That's okay. And it works most of the time. But the problem with that is two. Number one is the moment that I take a drill and I start drilling away some of that decay, there's always a possibility that I might elicit some pulpal sensitivity, either temporary or permanent. And that really bothers me because most of the time, a patient, they don't know that they have decay. They haven't had any symptoms. They haven't had any problems. They come to see me just because they're due for their regular dental checkups. And I tell them, yo, man, you have a cavity. I need to drill on this. They have it done. They pay me money. They take time out of work or time away from their families. They have me stick a needle in their mouth and drill away that decay, refill it. And then later they say, doc, I can't really drink cold water anymore, or I can't enjoy ice cream anymore on that side. That really, really bothers me. It's like I asked them to pay me so that I could help them, but what I ended up doing is I harmed them. That really bothers me. That's number one. Number two is those instances where a patient comes to see me, they have a pretty deep cavity, but it doesn't hurt. And I am faced with this dilemma. I say, okay, this guy's completely asymptomatic. They came in for their regular checkup, but they have a huge cavity. And now I have to break the news to them that, this tooth, even though it's asymptomatic, it might need a root canal. And in order for me to do a root canal, I got to charge you for the root canal, the buildup, and the crown, which is going to be very expensive with or without a dental insurance. It's going to be very destructive. It's going to be very time consuming. And there is a possibility that you're going to be skeptical. I mean, think about it. Just put yourself in your patient's shoes. You've had no symptoms, life is pretty good, and then all of a sudden, some professional tells you that you're going to need some incredibly invasive procedure that you had no idea that you needed. Those two things stress me out. The possibility of doing a routine procedure and causing pain, or the conversation that I have to have with a patient in which I have to do something incredibly invasive that they never knew that they had. So I want to talk about a particular product that I learned about 7 or 8 years ago that I'm very surprised that more dentists haven't caught on to. And that's the idea of bioactive composites. Okay, so I want you to think about your normal composite. It either comes in a flowable syringe or it comes in a little compule that you use when you want to do a packable type of composite technique. And that composite, if it is not bioactive, that composite is relatively inert. It does a good job of filling the hole that you created, but it doesn't do any chemical activity once it's filled that hole. It fills the hole, it makes sure that food and crud doesn't get in there, but it doesn't do anything from a chemical perspective to treat the surrounding tissue, whether it's surrounding dentin, surrounding enamel, or just the environment, the oral environment. Bioactive composites are different. Bioactive composites, the one that I use in particular is called Beauty Fill, and the bioactive composite that it has in it is called Giomer. This Giomer composite, basically it's regular composite. It looks, acts, feels like regular composite, but throughout the lifetime of this bioactive composite, it's constantly releasing ions into the surrounding area. So the number one ion that it's constantly releasing is fluoride. And I don't think that I have to teach any of you about the benefit of having fluoride constantly released in an area that is demineralizing and remineralizing at a rate that's pretty common for the standard American diet, in which people eat a lot of sugar. So having a composite that's constantly aiding in the remineralization process, that sounds pretty good. It's going to do more to grow more dentin, to grow denser hydroxyapatite, to make it so that that filling that you just did is going to have the lowest chance of having sensitivity. That's one of the ions, but there's actually quite a few other ions. Strontium is the other one. Strontium is a major acid neutralizer. And so that composite, which behaves like any other, that composite is now going to have releasing from it strontium ions. Along with that, there's sodium ions, borate ions, aluminum ions, silicate ions. And even because I'm not a chemist, I'm not a scientist, I'm not going to go into the details of how all of those ions work. But what you end up with is a composite that does three things. First of all, it's going to neutralize the area closest to the pulp. It's going to make it so that whatever nerves have come from the pulp through the dentin towards that prep, those nerves are going to be more neutralized, less prone to sensitivity. That's a big one. Number two is it's actually going to aid in the rebuilding of hydroxyapatite in the dentin and enamel that surround that filling. So that's great. That's excellent, especially based on the fact that most of the composites we do are going to have some type of micro leakage. It would be nice to have a composite that actually initiates a little bit of additional hydroxyapatite growth. So that's cool. Number three, which I think is really important, is that these ions, they create a bacteriostatic environment directly at the margin between your composite and your tooth. So let's talk about that brown line that we often see along the margins of our composites after a couple of years. That's really common, and it's not really your fault. The fact is the patient has a particular salivary and oral environment that ultimately leads to some type of breakdown of the margin between a really well done composite filling. If you put a composite in that has that bacteriostatic nature, what would end up happening is at the margin, there will be less accumulation of bacteria and therefore less of a brown line. And better than that is less of a chance of recurrent decay. What I think is so amazing about this is there are other products that are bioactive. I mean, the most common is a glass ionomer. A resin-modified glass ionomer is very similar in terms of its bioactivity. The only problem with the glass ionomer is it has none of the same physical features of composite. Glass ionomer isn't going to have the same type of polish. It's not going to have the packability that you're used to from your favorite packable composite. So glass ionomers exist and they have a place. But if you want to have the same polishability, the same packability, the same sculptability of your regular composite, just use a bioactive composite like Shofu's Beauty Fill composite. That one, they have such a line of different types of viscosities and different packability. You will find a composite amongst their line that's going to work really well, very similar to the composite that you already use. The only difference is it's bioactive. So you place that composite like you place any other composite, but it's going to continue working long after that patient leaves. It reduces stress. It makes it so that your chances of sensitivity afterwards are less. And it makes it so that when you have a really deep filling and you're worried about a root canal, you have a much higher chance for that deep filling to work out.